Thanks everyone for joining. This is actually a short lecture, but appreciate your being here. We're just going to talk a little bit about Vexus, which has received a lot of attention recently in terms of evaluation of the fluid overloaded patient and whether or not it can serve as a surrogate for other metrics of overall fluid status, but primarily in the overloaded state. No disclosures. So overall, we see this all over the place in terms of discussing how the critically ill patient is particularly in the pediatric sepsis patient, has their overall mortality associated with their total fluid balance early on and throughout their admission. And the question as to whether or not we could use ultrasound as a way to evaluate overload and be able to quantify it and use it as a target in therapy has been raised, since for time immemorial. And the thought with ultrasound is just that this will save us from having to put in an IJ and checking their CVP. And though there's always been controversy over the accuracy of CVP, we know that it does seem to have a lot of positive predictive value in terms of a number of the patients that we see, at least at the extremes of their values in the right therapeutic sense. And it's enough that we haven't given it up. So looking for other targets, we can always have ongoing interest in whether or not ultrasound can do that for us. But we know that just like CVP, there's also the confounders of other compartment pressures, and with a lot of the work that's been done, at places like CHOP and in various other IVC forward types of fluid resuscitation research. The literature is now rife with examples of how it doesn't help us, especially when the intrathoracic pressure is high, or we have variable compartment pressures also in the abdomen, or there can be measurement problems in terms of using M mode versus trying to use 2D measurements, and other factors as well, including RV failure and congestion from other sources. So if we can get it down better, could we use a ultrasound index to titrate our removal strategies better, tell us when we need to get dialysis on faster? So Bibin Saligny in 2020 published a really interesting paper in the Ultrasound Journal. This is a open access journal that is targeted primarily to folks from all over, to try to use Doppler data they've been able to derive from their patient population to come up with a fluid overload scale that's not as prone to confounders based on venous return. And the idea was Vexus, which was pretty much named a priori. And the idea was that instead of trying to look at the caliber of the IVC or venous distension, let's look at the idea of whether or not congestion of various organs would alter the venous return coming from them, knowing that there's multiple factors to consider in whether or not someone's fluid overloaded. A situation where we have in various shock states, we could have a low flow state, but if we have low perfusion pressures, we could still have high central venous pressure. And so we'd be differentiating that situation, especially if volume was an ongoing problem with that patient in terms of being overloaded. Or alternatively, if everything is congested, we could have very high driving pressures, but also high interstitial pressures in a perfused organ and end up with low venous flow. And how do we balance all these things out? So the idea was like, let's take a look in a couple of different places in the belly. Let's look at the IVC to get a good sense for where we are in terms of what we can generally characterize as maybe our ballpark fluid status, though clearly knowing there's some caveats to that. Let's look at the portal vein to look at the splanchnic perfusion. How well is venous flow coming out of the mesentery, and how easily does it flow through the liver? How congested is the liver? And also looking at the kidneys, and looking at the venous return there as well, thinking that ongoing kidney injury and congestion could contribute to impedance in vascular and venous return. The paper looked at 145 patients in a prospective study examining cardiac surgery recipients, and they looked at profiles of those vascular territories, and then came up a priori with several different models that they used. And when they compared the data from these scores with a predetermined severity scoring up there at the top, we'll go over more in depth later, in terms of what is normal, what is mild, what is severe, in terms of abnormalities of the hepatic vein flow, portal vein flow, and the intrarenal, it's actually the interlobar renal veins. When they use those different profiles, how associated were these profiles with markers of fluid overload and uh, impedance in venous return? So specifically, sorry, I'm just taking care of something here. How well did these things correlate with CVP, total fluid balance, and N-terminal proBNP? And overall, all of the tests performed kind of in the same ballpark, except the model for C was found to have a higher likelihood ratio of being able to determine whether or not someone had AKI. And so C was the one that won out, but not for bad reasons. As we can see from the graph at the top, when we compare in these leaf plots, the performance of Vexus C versus CVP, we have a higher likelihood of a positive test reflecting the actual outcome of interest, which would be AKI. The tests at the bottom compared Vexus C against central venous pressure on the left. And we can see that on the first 3 days after admission, there is an ongoing relationship between Vexus scoring for C and the patient's CVP. We can see in B with relations between the Vexus C score and N-terminal proBNP, similar performance throughout the first 3 days. So you can tell that, we do have some overlap of the whiskers here in all of these categories, reflecting the heterogeneity of the population. And then it falls apart a little bit as we get into total cumulative fluid balance, knowing the various issues that we have with cumulative fluid balance in terms of accuracy of recording, or whether or not congestion specifically has to do with total fluid balance or performance of the specific organ. These could all be considerations, but at least for day one, there was a noted association between the numbers. So going into how we do Vexus, one of the main things that we begin to have to think about is, what do Doppler venous return waveforms look like coming back to the heart? And you can find similarities between this in the hepatic vein, right where it comes in the right atrium, and also in the pulmonary veins as they enter the left atrium. But if we tie into the QRS, we know that initially when we have our atrial contraction with the P wave, we get a little bit of a positive inflection on our CVV tracing, as well as on our hepatic vein tracing. And in the hepatic vein tracing, we should think of stuff above the baseline as being flow that goes slightly backwards in the hepatic vein, as we measure it, and we'll have a view of that in a moment. Whereas flow forward is going to be related to partly initially systole, as the RV contracts, moves blood forward and stretches out the RA, and the RA then brings blood in, and systole will have initially some flow, but also in diastole, as we have emptying of the RA and we have total velocity forward going into the ventricle, we can see these two bumps as they happen. So typically we'll call this first one the S wave and the second one the D wave. The progression of this in the normal sense is, for hepatic vein, as we were just discussing, we normally have this type of morphology. S is usually greater than or at least approximate to D. And as dysfunction progresses, congestion of the right heart, our S wave becomes less prominent and our D wave may become more pronounced. And this can progress through the mild stage of dysfunction. And then in the severe classification, the S wave is reversed, and actually in systole, there's no forward flow through the cava into the RA, rather blood is regurgitated backwards into the hepatic vein. And for those of you who do echo know that this is not just an isolated phenomenon with venous congestion. This is also something that happens when you have tricuspid regurgitation and other forms of RV failure. The portal vein, we'll get into the anatomy of that in a moment, but as the normal characterization of the portal vein flow is such that we're looking at it coming from the mesentery up into the liver. So it tends to be flow towards the transducer. So it's net positive above the baseline. It'll be red coded flow if your colored flow Doppler is in the normal orientation of blue away, red towards, and it'll be a continuous flow that kind of like has a little bit of normal venous variation, but should be less than 30% pulsatility. As the liver becomes more and more congested and you've got more transmission of pressures from the arterial side through the liver parenchyma into the venous side, then you'll have more of a variance between systole and diastole noted in the overall flow in the range of 30 to 49% pulsatility, which is classified as a mild dysfunction in terms of the Vexus scaling system. Just ignore the division of these because up here on this third one for hepatic, this is mild, but on the third one for this tracing, it's severe. If you have more than 50% pulsatility variation in the portal vein flow, this is classified as severe in the Vexus scoring system. And then as that progresses and you have more and more pressure being transmitted from the arterial side to the venous side, then you can have flow reversal where flow actually crosses baseline and gets regurgitated back through the portal vein because the pressures in the liver are so high. So renal Doppler, what the interesting thing about this is that we don't do this a lot in POCUS, but this is something where you really see how Doppler ends up being a little bit more helpful to you with the pulse wave than it does with the color flow and with the 2D imaging, because the pulse wave can be more sensitive to overall movement. And so what you do is you get your view on the kidney, and then you can put the pulse wave Doppler box inside of the kidney in where you see some Doppler flow, and you'll be able to see arterial and venous flow at the same time. And in the normal state, we'll be able to pick up arterial flow that's usually towards the probe, as the parenchyma and the cortex of the kidney are going to be closer to your probe than the artery is. So you'll see the flow as like a A-line tracing for the renal artery flow, and the venous flow will be in the other direction and be kind of continuous, much in the same way as the portal vein flow is continuous. And as pressures in the kidney and on the parenchymal side increase, we get to see that pressure transmitted more and more, and the S and D phases of venous flow become discontinuous in mild dysfunction. And so as that progresses to severe, then we lose the S wave and we only see the diastolic wave. The places to look are going to be your traditional IVC window. You can look for your portal flow. Usually folks are looking kind of in the mid-axillary line, like alongside the right side of the liver, but not as far back as when you're doing your FAST exam. Or you can also look for it kind of in the subxiphoid area. And then you can also put a probe on either side of the kidney and try to put a Doppler box into the Doppler signal within the kidney to get that intrarenal signal that we were mentioning. And the phases of doing a Vexus assessment are: one, obtain your IVC measurement, because in the schema of Vexus, you have to have a distended IVC to count as being scoreable. If you don't, then that is then you fall off of the Vexus scoring system. That brings in questions as to the utility of IVC measurements, but this is one of the things that the system is predicated on, and really shoots for trying to at least parse out the patients that may have variability in some of these signals for non-fluid overloaded reasons. And then you can obtain the hepatic portal and renal vessel measurements as in any order that you find useful. This is just to mention what hepatic vein flow looks like. So in the normal state, I'm sorry, it's not cycling. this is a sagittal view of the IVC from below the costal margin. We just have the probe oriented across the liver. Here's the IVC, and this is the hepatic vein flowing there. And so normally blue away, red towards, right? So on the spectrum, we can see that blue is flowing away from the probe. Drainage comes from the IVC towards the RA, so does hepatic vein flow as well. This is in pulmonary hypertension, which generates a signal not unlike what we might see in a congested Vexus patient. So this is, instead of seeing uniformly blue flow away from the skin and towards the RA in a normal state, we see oscillating flow. We see blue, red, blue, red, blue, red, with red being when systole occurs. So that is blood being regurgitated up through this distended hepatic vein. IVC is over here. But this would be a situation that would be consistent with what you would see in a fluid overload Vexus patient with a hepatic vein score in the severe category. And then this is just to demonstrate what normal hepatic vein flow would be. This is taken from Radiopedia, where we put the pulse wave Doppler gate into the hepatic vein, and we can see the S and D waves, and we see a little bit A wave there, with systole happening right about here, ending right about here, and this is the beginning of diastole right here. Some ways that you can try to find it, find some of the structures in the abdomen, I mean, are one, we can try to look for branches of the abdominal aorta as kind of a landmark to guiding where you're going. So in these images, going along with the indicator in radiology mode, sorry, this does flip the other way in terms of the body orientation. Head is to the left of the screen, feet are to the right. This is diaphragm here. This is liver here. We're looking back at the aorta here. This is the antrum of the stomach right here. And we're looking at the branches of the abdominal aorta as they come up. And so this is the celiac trunk as it comes up out of the aorta right below the liver. SMA will run parallel to the abdominal aorta down here. And we can follow that with the ultrasound, trace it upwards up through the base of the liver, and we can see how it begins to split into the hepatic and the splenorenal artery. Hepatic here, splenorenal over here. And then from there, we can trace it up towards the path of the portal vein. So you can look for the portal vein right where it comes up medially, or one can put the probe out here laterally to the vein and look inward and try to visualize the main portal vein that way, and be able to put a Doppler gate into that flow. And because it is flow that's coming from the mesentery out towards the periphery of the liver, it should be red flow, and it will have like a venous characteristic to when you Doppler it, as opposed to an arterial one. And this can just shows a little bit of the vagaries of that. So if we use that hepatic artery coming off the celiac trunk, we can trace it, and it'll run right next to the portal vein system. And we can see the difference between the arterial system and the venous system here, even though they're both red. The hepatic artery being here on the right with some blue aliasing happening in it in the artery because the velocity goes beyond the scale, versus the more continuous flow on the venous side. And this is just an example of Doppler each. If we put the Doppler gate into the portal vein, we get a much more venous looking tracing, as opposed to putting it into the hepatic artery, and we get something that looks more like an A-line tracing. And just some images showing changes as someone's Vexus score gets worse and worse. And so this would be, again, normal with our normal S and D waves here with the Doppler gate across the pulmonary, across the hepatic vein. And then here, as we put in someone who has worsening venous congestion, we see instead of this ASD type of orientation, we have AS flipped in the wrong direction, D, so this would be a severe waveform change. In the hepatic vein and in the portal vein, again, was we change from a more continuous or venous appearing flow, we can see more notching of that as someone's liver congestion gets worse and worse. Sorry, let me see why we're not advancing here. Okay. So renal interlobular venous Doppler, these images are from POCUS 101 because they're really nice. This is just an example of when you're looking at the kidney in profile, you put your Doppler box into the area where you can see when you can Doppler the flow off of these interlobar vessels. And then we're able to simultaneously capture the arterial tracing above the baseline as well as the venous tracing below the baseline. And we see the progression from relatively normal to a discontinuous pattern consistent with mild injury to a diastolic only flow pattern associated with more severe injury. There are a number of tools out there that you can easily download and keep on your phone just to be able to reference to try to scale scale what Vexus is. And we have various grades that are used from the original paper to try to characterize severity. Ultimately, like outcomes are going to be dependent on population, and that wasn't something that was explored as much in the previous paper, though, the grades were primarily used for scaling of how severe the overall illness was. But there are a number of tools out there. They're all pretty useful for just being able to get some comparison images out there. So something to consider is just that a lot of the literature that is being published now seems to suggest that one of these values is more useful than the other, and that's the renal Doppler. There are various issues, of course, with the hepatic vein that we've already talked about, related to RV failure. Portal vein Doppler changes can happen in normal athletes. And so we might see a notching of the portal vein tracing in someone who's just, very good at marathons and stuff. And when we look at the original data from the paper that designed Vexus, we can see that when compared Vexus C, the one that ended up becoming Vexus as we know, the test characteristics of it are pretty approximate to what is seen for renal Doppler. To be fair, you can also see some of that in hepatic vein Doppler and portal Doppler as well, but there's been more attention towards whether or not renal Doppler is where most of the business is and has been associated, as we'll discuss a little bit later, with AKI as something that's been then it's akin to the original paper, but has been gained more attention is whether or not this could be something that's more indicative of AKI risk. So limitations are pretty glaring. Like, what's the IVC cutoff in children? Because we have this problem with kids all the time. It's like we don't know what the normal IVC cutoff should be for some of the translations of this adult data. And with some of the great work done by Lei Chen up at Yale, we've taken to using the aorta as a standard. The papers, they're not allowed out there right now, and so we'll get to it later. But the one paper that's out there right now uses IVC standards that were published by Kathiria et al. And it just leaves open the question as to whether or not Z-scores and age-based standards or aorta might be ways to try to classify these patients. And I think really the reason for the IVC cutoff is just to exclude the population of people who just happen to have weird signals, honestly, because it's just a means of kind of at least getting into the ballpark of patients who are more sick than not. So it's important to also recognize in the original paper, critical illness was excluded in the initial paper, though some of these patients were on pressors. Other issues were also renal disease, portal vein issues, and delirium, specifically known structural kidney disease, known VOD, and cirrhosis, and otherwise issues that would probably place the patients in a more sick category. And I know the question comes up, how could they be on pressors but non-critical illness? Don't know how to answer that one, but that was something that was in the original paper. For confounders, we have, of course, patients in the cardiac realm that have arrhythmia. That's going to throw off some of the measurements. Patients with heart failure, specifically right-sided heart failure, PH, structural congenital heart disease, or structural tricuspid valve issues would, by implication, throw off the interpretability of the hepatic vein tracing. The thing is that, heart failure in itself is associated in many cases with fluid overload. So Whether or not it's a true confounder or whether it could be a connection here is something that would need to be parsed out. And then, of course, mechanical circulatory support would throw everything off as well in terms of reducing the pulsatility of the systemic side pressures. Renal disease, structural or acquired, is we know that AKI is related to some of the things that we see with Vexus, whether or not renal disease that is inborn, cystic disease or other disruptions of the arterial bed. We don't know what interaction those have with Vexus. And then liver vascular disease, veno-occlusive disease is an important one, as well for our onc-ICU patients, as well as cirrhosis for our transplant patients. So there are two papers out there. One is the Best Fit T3 case series that was by Nataraj and Ranjit in 2022. Ranjit is also the author in one of PCCM's papers about the utility of echocardiography in guiding management and resuscitation, also a great read. And then that was a 10-patient series that used a variety of ultrasound metrics to try to guide resuscitation. And then Menendez-Suso in Journal of Ultrasound Medicine in 2023 published a prospective observational cohort on 33 children where they're being evaluated in critical illness, where they're being evaluated with Vexus, and it was associated with CVP measurements. This is another one of the papers that found that only intrarenal Doppler was relevant in terms of being an independent predictor of overall CVP and indicators of fluid overload. And using the same metrics that we've seen earlier in this talk, as demonstrated in the image on the left, they found that when we compared Vexus grade to CVP versus, looking at IVC diameter, Vexus was able to do better discrimination in terms of picking out the patients that were going to have a higher filling pressure on the right heart. The thing to also note, though, is that there are only 2 Vexus 2 patients and 2 Vexus 3 patients. So clearly there's more room to expand on this literature. So like with everything in POCUS, though, when we get into these specialized studies, there's a lot to be gained, from being able to apply the imaging to other situations. Just like the FAST scan is typically looked at as the gateway for a lot of people to pick up on some of their POCUS skills. And so this study was interestingly published in a BMT journal almost 20 years ago now. But using a sonocyte, they looked at 9 VOD patients among 36 BMT recipients that were screened a priori and identified VOD, looking at the portal vein, looking at the overall change in the appearance of the vein as VOD progressed and as they treated it, and were able to identify recovery of normal flow in the portal vein as they were able to treat VOD with the same types of images that we would obtain in Vexus for portal vein imaging, and also characterize the overall progression of worsening VOD here, going from A, B, C, and D. We see the notching of the portal vein tracing that progresses in the same way that we've identified in Vexus. So in summary, Vexus seems related to fluid overload. Does not necessarily seem related to fluid responsiveness. It's an important thing to mention. Some of the emerging literature that's coming out does make a distinction in saying that just because you have a high Vexus score doesn't mean you're not fluid responsive, which goes along with the logic that sure your liver might be congested, but you're still not there on your Starling curve in terms of being beyond what a test of volume would help you with. And the effect of other disease is not completely clear. The applicability and utility in children is not clear, though the adult evidence continues to be glowing in terms of just being a secondary indicator of overall fluid overload. And then the imaging skills that you gain in this may also have relevance in other applications as well. And that's it.